Thank you. Thank you for this opportunity. Am I audible?
Yes, Dr. Laxmi, you're audible.
Okay, then I will start. I'm going to present our research and the topic mental health status of the woman who have fertility issue and factors associated with this issue. And myself, Laxmi Gautam, and my colleague Pragya Kumar had primarily conducted this study. And previously, I was faculty at Manmohan Memorial Institute of Health Science, but currently I have joined PhD in Department Academy of Health Sciences, and I'm PhD scholar there. These are the content of my presentation. In the background, we'll talk about some issues of infertility. Infertility, it's a multi-dimensional stressor associated with different social and mental health problems. We all are aware about that, and approximately 21% experience infertility throughout their lives, according to different study. And WHO depression statistics define prevalence among female is almost 50% higher than males. The depression is more prevalent among women primarily. And after 4 to 6 years of infertility, depression and anxiety are most typical among the women. And severe depression was reported in a individual who had been infertile for 7 to 9 years. Then 40% had depression and 86% had anxiety. So when time goes on with the issue of fertility, then mental health problem also rise along with that issue. Then why we have to focus on infertility? Because it is a persistent stressor which leads to different strong emotional problem, dissatisfaction, and the risk of psychological distress is there with infertility issue. And why women in our patriarchal society, patriarchal culture in our Southeast Asia, where motherhood is sole way to advance in the family and community, and women are responsible for infertility regardless of whether the medical cause is with her or with her spouse. Commonly, what happened in our society, women are blamed for infertility, even though the cause is not sure or the cause is with her partner. And why we need intervention? It's a development of specific psychological intervention for women in order to help them manage potential mental health problem while meeting their reproductive goal. We have to address the problem of fertility among the women, and our research objective was to assess the mental health status and its associated factor among women with fertility issue visiting fertility center in Kathmandu, Nepal. And our specific objectives of the study was to determine the mental health status of women with fertility issue visiting fertility center in Kathmandu, then to assess the factors influencing mental health status of women in the center, then to explore the association between mental health status and other factors. This was our conceptual framework with variables. Then going to the methodology, the study method was quantitative research method, and study design was cross-sectional. Study time was October 2023 to April 2024. Study site was Vatsalya Natural IVF in Kathmandu. Study population was women with fertility issue. Our sample size was 143 and sampling technique was simple random sampling. In inclusion criteria, women unable to conceive after a year of unprotected sexual intercourse, which is defined as infertility, and exclusion was those women who experienced major life event and who had completed the treatment during our study period were excluded from the study. Then semi-structured questionnaire was developed to measure the socio-demographic information and other information, while DAS-21 was used to measure the mental health status. Data collection technique was face-to-face interview, and we had done pre-testing in another fertility center with 10%, that was 14 sample size. And in ethical consideration, ethical approval was taken from Manmohan Memorial Institute of Health Sciences Institutional Review Committee. And then a written informed consent from each respondent. Participants were informed about the study's objectives and their freedom to withdraw, not taking part, all the ethical issues. Together with confidentiality of the participants was also mentioned. Let's go to the major findings of the study. In socio-demographic variables, majority of the respondent was 20 to 30, 30 to 40 years, that was 51.7%. And the highest educational level was secondary level of education followed by university degree. And most of the majority of the respondent were from joint family. Then age at marriage was 24 with IQR 5, and majority of them were more than 24 years of age, and duration of marriage was more than 15 years for 23.8%, while less than 5 years for 33%. Total monthly income, median plus IQR was 60,000 plus minus 50,000. There's the data was diverse, and majority had more than 60,000 Nepali rupees per month income, and permanent address. Majority of the respondents were from out of Kathmandu Valley, even though the treatment center was in Kathmandu. Working status, 16.8% of the respondents had quit their job due to the treatment, and 70% of them were engaged in service center. And we all know that visiting the fertility center is not a single time task, and for the treatment of fertility, they have to visit the clinic multiple times. So those women who were working felt difficulty, 45% felt difficult, and 23, almost 1/4, were reporting that they felt very difficult to visit the clinic while they are still working. So they have to take the leave daily basis, which must be difficult for them. Then changes in family behavior, whether they feel the changes in family behavior once they are because of their infertility, and 76 of them didn't feel so, while 1/4 feel this. Their family behavior was changed, and how changed and what happened, how they feel. They describe accused of not having the care of the family, accused of being ill, and 14% tell that often their husband were asked to remarry because of the fertility issue, and they feel it was very important to have children. Maybe some have a personal opinion that they don't feel important to have children, but the respondents, 86.7% feel that it was very important to have child, and 72% feel insecure because they are not having a child, and marital satisfaction was among 77.6%, and most of them have primary infertility, and the duration of infertility was more than 5 years for 42%. Then factors of infertility, 62% had female factors of infertility, while 10.5% were having male factors infertility, and most of them are, almost half of them were already received treatment. That was not their first time. Duration of getting treatment was more than 5 years for 22.4%, while less than 2 years for around 60%. And treatment related factors, infertility shared with family, only 56% had shared with this family, and why they don't share with the family was because they feel uncomfortable because of the fear of being judgment. And financial burden, almost half of them feel financial burden, and because of the cost, they had problem in treatment, and they have to spend their all saving, salary, or house rent to manage for the treatment. And women with infertility were not involved in social activities. 29% of them. Why they do not involved in social activities? Because fear of judgment and stress. Always people ask for child because they feel discomfort when other people, women have child, and no free time from house and office work because they already taken break from the work because of the hospital or clinic visit. And almost more than half of them feel social stigma because of infertility. And what type of social stigma they feel? They were accused of being bas. Bas means infertile. Then judgment on personality and negative comment and many other offensive comment they feel in the community. And 30% were abused because of infertility. And the abuser was, they feel the society was the main abuser, followed by in-laws and husbands, other family members, relatives. Types of abuse, verbal and emotional abuse was the most. And this is the DAS scale we use to analyze the mental health status. And we can see that severe, extremely severe stress was among 1.4, while severe stress was among 14%. And in anxiety, 14.7% feel severe anxiety, and extreme anxiety was 11.2%. And in depression, 2.8 have severe depression, and 0.7 has extremely severe depression, while 11.9% has moderate level of depression. And we analyze the data further using the multiple logistic regression. Once we gone for the chi-square test, and those variable who shows the association were further analyzed using multiple logistic regression. And insecure about not having a child was 3.19 times higher among those who feel insecure in comparison to not feeling insecure. Similarly, in reference to no social stigma, those who have social stigma have 2.91% odd of having stress. Then association between anxiety and other factor. In anxiety, we can see never conceived and conceived but no live children, or have higher odd of having anxiety in comparison to had to conceive, not conceived at all, or had to conceive now. Then goes for the another one. Social stigma and financial burden are also the positive factor for anxiety. Then next, logistic regression for depression and other factor. And here marital satisfaction shows relationship with depression, and those who were not satisfied or neutral in the marital relationship or satisfaction or 4.3 times more higher at risk of likelihood of risk of having depression in comparison to those who are satisfied with their marital life. Similarly, depression was associated with factor of infertility, and in reference to unexplained infertility, male factors infertility had 3.9 times the likelihood of having depression, while female infertility was 14 times. Those female who are having infertility because of female factor are at a risk of 14.14 times likely to develop depression. And then duration of treatment, the longer the duration of treatment, the higher the likelihood of having depression. And treatment cost also follow the similar pattern. We may not go for the discussion now because we may not have long time for that. So going for the limitations of the study, our study was conducted in single center with finite population. However, the selected center has the highest patient volume in Kathmandu district, and the patient who visit the fertility center, 62% were from outside the Kathmandu Valley, which may represent the whole country. And evidently, the next is exclusion of other center due to logistic and regulatory constraints. The fertility centers were not willing to participate in the research, maybe because of their own conditions and problems. Data were based on self-reported measures which may be subject to recall and social desirability bias. In conclusion, this study identified psychological distress among women with fertility issue during the course of treatment. Majority of the women had anxiety, followed by half of the women with stress, and nearly one-third of women had some level of depression, which is significantly related to primary infertility. The findings show that higher association between mental health status of women with fertility issue with mostly social and treatment-related factors like insecurity, social stigma, abuse, parity, duration of treatment, factors of infertility, treatment cost, and financial burden. These social and treatment-related factors create a complex interplay that impacts the mental health status of women facing fertility issues. So our recommendation is that prompt psychological intervention should be focused during the treatment course through clinics and hospitals. Focus on proper couple counseling in IVF center as factor of infertility often misinterpreted often between couple. Provision of insurance scheme in IVF treatment as it creates high financial burden, treatment delay or discontinuation. Focus on treatment management by clinics waiting time as the treatment has led to higher percentage of women leaving their job. And community people over the and free from judgment and stereotype for infertility. It's factor as well as treatment for the women who are already facing the problem of infertility to live comfortably in their society. We can acknowledge them, and these are the references. Thank you.
Thank you,
Please,
Dr.
if you have
Laxmi.
any queries.
Thank you, Dr. Laxmi. And it
Thank
was
you.
really insightful to listen to your exact work. This is your exact work, right?
Yeah, we did this.
Okay. And I saw that you have done this on 143 participants.
Yes.
That was really indeed a good one to listen from. And dear participants, the floor is now open for question answers. If you have any query, if you have any questions, please go ahead.
Hi, Laxmi. I have a question.
Hi. Go ahead, please.
Yes. So I want to know that what statistical tool did you use to derive the result, and is it the best way? Why is that best?
Statistical tool, we use SPSS to analyze the data.
Okay.
And maybe we could use Stata or other statistical tool, but SPSS has managed to meet our objective, so we use SPSS for the data analysis.
And the result you showed were actually your real results. So
Yes.
I really enjoyed listening to you now.
Thank you.
Thank you, Dr. Laxmi. Thank you for your very beautiful presentation, very insightful presentation, and thank you for being with us. Please be with us for the next duration for the full day for our next speakers. And